We can go ahead and get started.
Okay. Thanks everyone for attending today. This is Pat Doyle, Executive Vice President, Chief Development Officer with Cignet Health. Cignet is a strategic business partner with Vizient for acute physical rehab services and also for behavioral health services. Today, I have Tish Anderson, Executive VP over our rehabilitation division, and we have put together an overview for acute rehab services and the resources it can bring to bear for potential needs and opportunities in your community. So the first part of this presentation will be Tish discussing about background overview of acute rehab services. Tish?
Next slide, please. Good afternoon, everyone, and thank you for joining us today. I would like to begin by telling you a little bit about who Cignet Health is and our ownership. We have been owned and operated by the Browder family since 1999. And that's who you see on the left side of the screen. That is the majority of our board of directors. We are privately held, family owned, as I said, and we now partner with over 80 hospitals in 30 states. 1999 to 2021 of January this year, or in January 2021 of this year, Jerry Browder, our owner, and his family acquired Diamond Healthcare. So now we are the largest provider of contract management services for behavioral health. And prior to the pandemic, we started the acute care division for inpatient physical rehab. We have partnerships, contract management relationships with hospitals all over the country. Our services are divided between the two divisions with regard to opening new facilities, new units from the ground up. We participate in facility design, everything from A to Z, as well as enhancing existing operations. We as a company, since the beginning of Cignet, have never paid a settlement of any kind or been investigated by the OIG, and we're a very flexible partner. Next slide. I would like to describe to you today a little bit about acute inpatient physical rehabilitation. I want to be able to distinguish acute rehab from other models of rehab that you may be familiar with, such as LTAC or SNF or outpatient. But acute inpatient rehab, or an ARU, is known to short-term acute care hospitals as a unit that is within the facility, but that receives a different form of reimbursement than the other parts of the hospital. A freestanding IRF is may be familiar to you because it is also referred to in the rehab industry as a freestanding location. And it may be separately owned, and it may be a joint venture between a hospital and an entity that shares ownership. These programs, whether it's a freestanding IRF or a hospital-based unit, are valuable components provided by the Medicare program because they assist the acute care side of the hospital with decreasing their length of stay by offering patients, families, and physicians a step down into a next level of care because the patient is not safe to go home. So by providing rehab inside the facility, the patient can graduate from an acute rehab unit into their home care setting. Next slide. As I just said, IRF patients or rehab patients typically transfer from a general acute care hospital. they've been admitted through the emergency department for a traumatic event or a complex condition. They may have fallen, fractured a hip, they may have had a stroke, they may have had an exacerbation of their multiple sclerosis or COPD. Those are generally the types of admissions that acute rehab units and freestanding IRFs treat. But again, these patients are not safe to go home yet. So the intensity of a coordinated plan of physical therapy, occupational therapy, and or speech, swallowing therapy, along with continued medical observation and guidance. And we'll get into that in a minute. But that's the reason that patients easily qualify based on some of these diagnoses to be admitted and transferred into a rehab unit. Next slide. So CMS, as you know, has a lot of stringent requirements, and these units are especially required to follow very stringent admission criteria, especially. So to even begin to consider a patient for admission to an ARU, there is a clinical liaison, usually a registered nurse, whose primary responsibility it is to assess patients. That assessment can take 45 minutes to an hour because it includes a face-to-face interview, reading of the record, interviews with family members to determine the safe discharge and the potential for their discharge, physicians, and then we're also reviewing patients for the qualifying conditions that they meet. CMS has a very, very specific list. This list has been in existence for a very, very long time. It hasn't changed much in the last 25 plus years. So there are categories that patients have to fall in. At 60%, we monitor that daily on discharge. The balance of 40% do have to qualify by a diagnostic category, but they have to meet all the other criteria. All that other criteria includes being medically stable, being able to tolerate a therapy program that is pretty intense and requires a minimum participation of 3 hours on a daily basis. Next slide, please. As I said, we offer support and consultation and management of new acute rehab units as well as established rehab units. We will analyze your internal data based on a year's worth of DRGs, and the internal demand, the demand that you would be able to support and depending on the capacity of the unit, is about 70% of your census. 70% of patients from a rehab unit originate within the facility, within the hospital. Neurological service is a must because neurological conditions, in addition to stroke, really comprise the majority of admissions to a rehab program. Neurological services is really an umbrella term for MS, even neuropathy, other brain injury. Those are, there are quite a few reimbursement categories just under the scope of neurological services. So without neurological services and strokes, we would be left with major traumas, complex orthopedics, and that usually doesn't support the need for a hospital-based unit. Our management model has the preference to have a physician, a physiatrist who specializes in physical medicine and rehab, an MD or DO as the medical director. Referring physicians, whether inside or outside the facility, prefer to refer to a specialist in this field. Although CMS has relaxed the requirements for the medical director, other physicians regardless of their medical specialty, may qualify to serve as a medical director as long as they have 2 years of experience treating this population. In addition, there are PT, OT, and speech requirements for a minimum of 3 hours of therapy a day. The majority of patients receive physical and occupational therapy. With this neurological component to the rehab unit, speech therapy is also pretty consistently utilized. The combination of those 3 disciplines equal the 3 hours of therapy a day. They're divided into increments of usually 45 minutes, beginning in the morning with OT and rehab nurses assisting with the breakfast, bathing, and grooming, and then PTs scheduled throughout the day several times for mobility, whether it's mobility walking in the hallway of the unit or in a therapy gym, which is preferably located on the unit. Patients, you know, we like to emphasize this part. If you have, again, neurological services and other complementary rehab related diagnoses in your facility, such as complex orthopedics, there is a valid reason to really open your own unit instead of send the patient and their family out to an outside facility, because that travel for an average length of stay of 14 days can be very hard on older adults. The average age of a patient in rehab is about 75 years old. Next slide. The primary reason patients are candidates and are admitted to the rehab unit is because they remain functionally dependent on others to meet their basic needs, their daily general needs, their activities of daily living. Again, this population tends to be 65 and over. However, younger patients younger than 65 definitely can meet criteria. The difference is the payer source. Commercial payers do approve rehab, although sometimes they have a preference for skilled, but I've been involved in many examples of peer-to-peer discussions to support the admission to a short-term intense hospital-based rehab program, rather than have a younger person, say, you know, in their 30s, 40s, or 50s, be sent out to a skilled facility with a less intensive program and less coordinated care. The data shows that intense hospital-based rehab programs tend to save patients money, reduce readmission rates, and improve outcomes. Next slide. Recovering COVID-19 patients really in the rehab industry have benefited tremendously. Their outcomes and their discharges home after a lengthy hospitalization has really been an impressive outcome for acute inpatient rehab. In my recent experience, patients that were hospitalized, and again, patients that I'm personally familiar with on the rehab unit that I happen to be at, they were in their 40s and early 50s, had lengthy hospitalizations, were on ventilators, and only had about a 10 to 12 day length of stay on the rehab unit before being discharged home. Next slide, please. So again, I just want to review quickly the other criteria for the admission requirements. In addition to all those diagnostic categories, again, the most common: stroke, neuro, complex lower extremity fracture. That's the 60% of patients admitted must be in those very familiar rehab diagnostic categories. Someone without one of those, like say, for example, a COPD patient, they have to still be able to voluntarily commit to participate in the rehab program. when a liaison is talking to the patient while they're in med surg and really describing the program, saying, you will be able to go home and you will be safer. You will be able to, you won't be so winded or breathless after, just trying to put on your shoes or getting dressed. We're going to build up your tolerance and your strength, your balance, and you'll just be safer. If they get there to rehab and change their mind, they can't stay. Medicare will not continue to allow any payer will not allow a patient to not participate. The clock begins ticking in these units and in these programs when the patient is admitted. So whether we qualify a patient regardless of their diagnostic category, any patient on the rehab unit is required to also be able to demonstrate that they're participating and demonstrate that they benefit from the program. Again, 3 hours of therapy a day, at least 5 days out of 7. 7 days means the begins on the day of admission, and it's 7 consecutive calendar days. So in managing these programs and creating these programs, we make sure that physicians and everyone understands that, because rehab is no longer a 5-day-a-week service line for hospitals. Therapy needs to be available, rehab nursing, all the components to the program need to be well documented, enforced, and in place consistently 7 days a week. Next slide. For a new IRF, which is an inpatient rehab facility, I'm sorry if I didn't spell that out sooner, or an ARU, the external target markets are very, very broad. So long-term care and SNF programs tend to promote themselves as rehab centers. And the lay community, adult children, especially adults 65 and over, may not be as educated as we are. And they say rehab, and they aggressively market themselves as rehab centers. There's a tremendous amount of difference between a long-term care SNF rehab center and there is a hospital-based acute rehab unit. We also, there are CMS guidelines for transfers between long-term care SNFs and acute rehab units. So I probably won't get into that, but that would be a follow-up conversation. In our marketing efforts, we do tend to contact and reach out and try to have a relationship with long-term care centers, because there are patients that they should not be taking in a skilled level of rehab. And the patient may still need to be more closely and medically monitored and is best served in a hospital setting. Short-term acute care hospitals, we target case managers and physicians, find out where they are sending their patients. Home health do a lot of home-based rehab. Home health nurses and therapists need to know that they can contact a hospital-based rehab unit in the event a patient begins a decline while in their care. We also have external community groups, market to senior groups, senior associations, AARPs, any assisted living buildings. We go door to door to primary care physician offices. Ideally, in the course of the physician's day, if they're looking at a patient in their office and they think that they would have concerns about them going home and being safe, they will call the rehab unit and have us we would come over and assess that patient on site. There is no requirement for where a patient needs to come from. There is not a 3 midnight stay requirement like there is for a SNF. A SNF rehab center can only admit a patient from a hospital if they've been there 3 midnights, and that's not the case. Patients can come from home. directly into an ARU. LTACs are also a source of an external marketing target. They provide a much different level of rehab. Next slide. Mm. 60 plus to 70% of payers are traditional Medicare. This reimbursement system, the qualifying criteria, every regulation is based on a traditional Medicare patient. Hospital census drives 70% of the internal admissions to the unit. So for example, the rehab unit will have a clinical liaison whose primary responsibility it is to educate, to huddle, to integrate with the hospital resources, case management primarily. They are circulating, not shy about asking, do you have anyone that's not safe to go home today? Do you have anyone that we can work with? And so that begins our process of, again, screening patients into the rehab unit and making sure that they meet all the other criteria. Hospital case managers and referring physicians don't know the list and the length and all the other reasons that a patient can come to rehab. They usually know that they might need help walking, but they may not realize that rehab nursing is a required component to an inpatient rehab unit by CMS. So CMS requires that this level of specialty nursing be provided to every patient 24/7. So that one to me, that discipline to me sometimes is underestimated. So that means patients aren't sitting in their beds all weekend and not receiving any kind of rehabilitation care. Nurses get patients out of bed and up for meals on a rehab unit. They're not being served in their beds. Freestanding IRFs represent 22% of rehab providers, but treat 44% of acute physical rehab patients. In one market, for example, that we're monitoring right now, 12 freestanding rehab hospitals are being added in Florida. And LTAC, the regulations changed about 2 years ago. They can add ARUs. And LTACs, you may or may not know, have a lot of empty beds or a lot of non-revenue producing space. So they can carve out a unit within their LTAC and now also treat the same patients as an acute care hospital can. So ARUs and LTACs is fairly new. Next slide, please.
I'll talk a little about the financials for acute rehab units and also for freestanding rehab. On the previous slide, Tish pointed out that the majority of these referrals are coming from inside acute med-surg hospitals, usually about 70%. And yet the freestanding rehab providers have almost half the market. So what they're doing is taking the patients out of many acute med-surg hospitals that either do not have a unit or they have a unit and patients are so-called leaking out to other providers. They're not getting those patients caring for them. And there's such an advantage to care for them in a floor in your own building or right down the hall or on your campus, so they're not having to go out to another provider miles away, possibly. That being said, even a small 10-bed rehab unit can make financial sense with a break even of about 3 to 4 patients. As Tish pointed out, the majority of patients across the United States are traditional Medicare. It usually is between 60% and 70% of the patient days on these programs. So it's easy for a CFO to determine what the pro forma will look like, since they know roughly 70% of the payment ahead of time before the program opens. The average Medicare payment is about $22,000 per discharge. So with that type of reimbursement and a 13-day length of stay, it's not unusual for hospitals to be paid $1,500 a day and up on a Medicare patient on acute rehab, which is not high tech. It's primarily FTEs, therapists. The annual cash flow or EBITDA for a small unit with single-digit census, 7 to 9, for example, is usually over $1 million a year. And certainly if you have a bigger program, and we do run into hospitals that are 300 and 500 bed size, but they historically for years have sent them down the street or a few miles away to a freestanding rehab. And literally the profitability from the program can be $2-3 million for just treating the patients that they have inside the hospital. And frankly, we feel give them better care. Cumulative over 5 years can be over $10 million in cash flow. And that gets us into, why in some of our projects we're willing to help the hospital put up a building. Next slide. Did you want this, Tish?
Sure.
Yeah.
Acute rehab is very outcome oriented. We need to be able to demonstrate, as I've said, that patients benefit and they leave at a higher level of function than when they came in. So this is a national statistic. 76% of patients that are admitted to an acute inpatient rehab program, whether it's a freestanding or for an ARU, 76% are discharged to community or a home setting. I say community because it could be assisted living or their own home. The average age, again, is 75 and a half. Average length of stay is 13 days. And the average case mix index is 1.4, which we're seeing the case mix index increase gradually year to year. Patients are older, have more comorbidities, and are staying slightly longer. There are more avoidable readmission stays from when a patient is in an acute rehab unit. And the last bullet, the American Medical Rehab Providers Association is a national legislative organization in our industry. They issued a report recently that says patients admitted to an acute rehab program remained home nearly 2 months longer, had 5% fewer emergency department visits per year, returned home 2 weeks earlier, and showed an 8% lower mortality rate. And again, all of that data is collected on every single patient. CMS has, again, other transmission and submission requirements whereby we collect quality data, outcome data, reimbursement data, financial data, outcome data. Next slide.
So some of the enhancement goals of an acute rehab unit, about half of our activity are working with hospitals to enhance the performance of an existing program. Often it's a volume issue where it's a larger hospital. They have a fair amount of neurological active service lines and orthopedic, cardiac and COPD. And clearly with recovery from COVID, there seems to be a need for the service, but they do not quite run what they are expected. So we can, one, run their internal demand, see where their gaps are between the MSDRGs we think should generate admissions to the unit, and then what actually comes in on the unit within their case mix group, which are different classifications, and see if they are missing certain stroke cases or cardiac cases that might be able to benefit from that. And then about 30% of the activity on a unit should be external. And it's not unusual for us to talk to a hospital where they capture maybe 75%, 80% of the expected internal. And when you ask about external, they stare at you. There really is not a formal outreach. And then you go and look at the freestanding rehab hospitals, which in most of their cases, 100% of their admissions are external. If they don't have a joint venture, then they probably have people in your hospital today looking for patients to send to their facilities that, once again, we think could be treated more effectively within your own hospitals. And we can look at the UDS FIM data. There's a treasure trove of information there. Tish really understands this, has worked for it with decades, and can try to get an idea of why the patients are not making it to the unit. Sometimes it's not 7 days a week. Sometimes there's deflection going on by some of the staff for some of the sicker, older patients they're seeing. And many, many times there's easy increase in utilization for the unit. Next slide. Tish, physical plant.
The requirements, the physical plant requirements for a hospital-based unit are unique. So the square foot requirement for private room is 140 square feet, 125 if they're semi-private. Most rehab units now are private rooms. Private rooms are larger on rehab than med-surg because there's more equipment, there's more activity. They are very spacious. Everything is ADA compliant, wheelchair accessible. Some of the distinguishing physical plant features for a rehab unit are multi-purpose space for dining and combined activities, or dining separate. There should be, although it's not mandated, but it's highly preferred, and I've rarely seen it off the unit, but the treatment gym, the therapy gym, should also be on the unit space. So another regulatory requirement that, again, distinguishes rehab units from any other hospital unit is a transition apartment. That is space so that a patient and their family can transition from the rehab unit home. It's designed with furniture, furnished with a queen size bed, usually coffee table, bureaus, carpet, things that a patient and their family will be reintroduced to when they get home. So they may be considered obstacles or barriers, and safety precautions are practiced under supervision while they're on the unit. So that's a critical part of rehab. Patients and families sometimes spend the night in there the last couple of days before they're discharged from the unit. About 6,000 square feet to 10,000 square feet is a space that's needed to design an 8 to 20 bed acute rehab unit. And remember, these spaces for the dining room and activities in the transition apartment and the therapy gym are the places that patients are relearning and regaining their skills so that they can go home again and not be practicing these things for the first time without supervision. Next slide.
So Cigna can assess what your internal demand is, which would help you determine how much space you may need for a unit inside the hospital. We can also look externally at the marketplace to see and estimate hospitals in the area without programs, what their needs may be, and if those are potential referral sources for you. If it's a freestanding rehab hospital to be considered, you're probably going to need a facility, if it's a standalone rehab only, 30 to 40 beds to support it. So it would take a larger referral base or internal demand, which for some of the hospitals we talk to, they have that and we're able to consider partnering with them to put up a rehab hospital. Looking internally, Tish had mentioned congregate space areas. Sometimes in hospitals, those are already in place. It could be a former skilled nursing facility, could be a former behavioral health unit that have group rooms and day rooms that makes the conversion a little easier. Mm-hmm. Next slide. So the freestanding rehab hospitals that we're able to consider, really, as I mentioned, 30 to 40 bed size service area. Sometimes they can be on the smaller side of that. If we also are putting a behavioral health program, we do offer behavioral health services and have the ability to put up a brand new building that can have both service lines in them. And it not only makes the building expense less expensive to combine them together, but certainly the return on investment can look better as you have two service lines and more patients that you can service there. And on those, we will tailor it to what the hospital's goals are. The majority of hospitals we work with are not-for-profit. We are a family-owned business. We're not publicly traded. We can really match strategic long-term goals very well. We don't have quarterly ringing of the bell to answer to. So we feel very comfortable that we're able to partner with not-for-profit hospitals with aligned goals on such projects. Next slide. So this is just a picture of a building, but we do have projects we're looking at right now that are combining both service lines, behavioral health, and then also the acute physical rehab. And if you have a campus where there's not space within the walls of the hospital, certainly hospitals can look at land on their campus as part of the contribution of equity in such a joint venture project. Next slide. So there's my contact information if there's interest for further discussions on our services. And at this point, if anyone has any questions, certainly submit them and we'd be happy to answer.
We've had a few questions submitted here. I'm going to read them off for you. How can Signet help us determine if a facility makes sense for our marketplace?
Okay, if we're trying to determine if it's a unit inside the hospital or freestanding, the first thing we'd want to do is run your MSDRGs and then do an external market survey to determine what the bed need is internally, and then also forecast what the potential for external is. So it's fairly easy for us to do it. I've gotten in data within 24 hours of sending our data form to people, and we're happy to do that.
Okay, next question. What does Signet typically provide to the hospital as part of its acute physical rehabilitation services?
Tish?
Our management model includes the director of inpatient rehab, a clinical position for the PPS or prospective payment system component, which is a very valuable component to ensure compliance to all the regulations, the quality standards, as well as having someone make sure that reimbursement is accurate. And this is the person that assigns payment for the hospital. So that's a position that we make sure is an expert. And then a nurse liaison who's doing internal and external assessments to qualify patients for the unit. And again, preferably the medical director, the physiatrist.
I've got two questions here that seem related the answer you just had was, will Signet recruit the medical director, and also who does Signet employ?
We will recruit the medical director. Yes, we will, as an independent contractor, not an employee. An independent contractor who will, we will support them in every way possible, help them, with their billing. The hospital sometimes may or may not have additional service lines that they would like a physiatrist to lead, such as pain management or outpatient. So yes, we prefer to be a part of that.
Okay, got another question here. How has COVID affected the need for rehabilitation services in hospital settings?
We've learned a lot treating, recovering COVID patients. One of the primary diagnostic categories to rehabs historically has been COPD and other respiratory illnesses, but it hasn't been a primary admitting diagnostic category. But what we learned with COVID is patients are weak, deconditioned, need rebuilding, strengthening, safety measures, swallowing, speech therapy after a ventilator. So we've created programs now around recovering COVID patients. Rehab units don't typically take patients who need isolation protocols. Rehab units have to have at least one unit dedicated for isolation, but it can't be, we can't have multiple patients in isolation. So COVID patients, once they're discharged from med-surg, they no longer require isolation protocols, and they're ready to participate in therapy. Most likely they can tolerate a couple of hours of carefully planned therapy, 3 hours a day, but it's been a significant impact and a welcome impact, because every patient I'm aware of that was treated for COVID recovery was discharged home.
All right, next question. What could a hospital member or Signet partnership look like when building a new joint venture inpatient facility or pavilion?
I'll take that. It really, we'd have to look at the size of the need in the community. But if it's a project, and very often it could be a 400+ bed hospital that is provides trauma care, and they're a stroke center, and they may really have a need for such a pavilion on their campus. And we would look at that. And once again, they could have land that could be part of the equity contribution to the joint venture. And Signet can provide the capital to put up the building for such a service, and the hospital can have equity in the project. Signet would oversee the operation of the program to, of course, make sure we're meeting our clinical, operational, and financial goals. But it's a way for the hospital to truly get a state-of-the-art building on their campus, have access to capital if that's a need, and then partner with someone who's done this over and over again with rehab. Tish has helped do programs all over the country.
This question is a bit related. How long does it take to get a unit up and running?
Tish?
If it's a new unit, depends on the available physical plant space. As Pat said, if it's something that can be converted, I can remember years ago converting an existing nursery to a rehab unit. So the timeline that we have to work with is the physical plant design, the area CMS offices submission and filing the applications for the 855. That's usually only a 90 to 120 day timeline. Self-compliance, CMS really isn't sending out surveyors any longer to do on-site surveys or open or closed record reviews. So we're very comfortable saying 5 to 6 months for a new operation.
Yeah, I think if it's a building, once you decide to go forward with architectural planning, the building, you're looking 18 to 24 months to get the building.
Right.
Got 2 more questions here. As the boomer population is aging, what are you projecting as the growth need for rehabilitation?
Well, the 65 and older age group is growing pretty rapidly, and it's growing in 2019. It's funny you asked that because I read a statistic recently. In 2019, there were 54.1 million people over 65, and it's projected to increase to close to 80 million, I think in the late 2030s. So that population, the graying, is more active. Again, more comorbidities, the more people of this age group, 65 and over, and the average age being 75 and a half admitted to the unit, bring an average of at least 2 medical comorbidities with them to the unit. And those need to be continued to be managed on the unit. So I guess, you know, what I'm saying is, because the population is aging substantially, there will always be a need, and there is always going to be growth in the acute rehab industry.
Yeah, this is public data, and I'll quote it, but we mentioned there were 12 new rehab hospitals going up in Florida. I think it's at least 14 at this point since that slide was made. HCA, Hospital Corporation of America, a large company nationally, announced in Florida for units and rehab, they're going to invest $300 million to bring up new units. So HCA, which has been pretty successful, I live in the Dallas area. I've had kids delivered at HCA facilities, and they're investing heavily in adding acute rehab programs. So I think other hospital providers, I'm not trying to sell HCA stock here or anything, but they are moving on this because they see that there's a need going forward and they want to provide the care.
Last question, then then we can wrap up. Is there a difference for rehabilitation need in rural or urban hospitals?
A difference. Well, there's a difference in reimbursement if you have if you have a rural designation and an urban, it's more. You know, in my experience, I've worked with a lot of rural hospitals that have a solid 10-bed unit that operates at 75 to 80% capacity. So there is a need in both rural as well as urban markets.
Okay. That was all the questions that I've gotten. And Pat and Tish, if there's anything else you want to say.
Well, we want to thank Jenny Contreras for arranging this with Vizient. We're proud to be their sole strategic business partner for acute rehab, and look forward to conversations with member hospitals. Once again, we're able to provide free assessments. Is there a need in the community? If you have a program and you're trying to determine how to tweak it so it performs better, we can do that. There's typically no charge for that either. And Cigna will be at the Summit Connect in Las Vegas. And if there's interest in talking to us there in 2 weeks, we'll be out there. I'll be out there, and there's my contact information.
All right. Thank you for everyone for attending. Have a great day.